through directed exchange through our organization. We get a lot of queries, and we deliver a lot of data. So for example, back to the VA and the DoD, we're delivering out of those 5,000 patient discovery queries, we're delivering 700 documents a day back, CCDs, consolidated CCDs back a day. Interestingly, only about 90 are pulled down a day. So we see that pretty common throughout the entire infrastructure. There's a lot of data being exchanged, not a lot of data actually being used. And that's something that I think we would like to explore broader with eHealth and some of the bigger networks. We had planned on expanding our use of eHealth through different states and different important partners that sit outside of Ohio, like with West Virginia and Maryland. We do plan on going up on the hub early next year. We're excited. We are going to jump into the care quality space too, because we think that's absolutely crucial. So we're really trying to adopt a lot of what eHealth is doing because we don't have to do it. Be honest, we're trying to make sure how we stay relevant, which we can talk about a little bit later, but we see eHealth as a really critical partner to our future.
Yeah, we're using eHealth primarily for treatment purposes. We're live with the VA. To Dan's point, we're really excited when they're going to change over to the different model. Instead of being opt-in, they'll be opt-out. We can't wait for that to happen because we see a lot of, we get a lot of positive responses, but we're unable to share that information because the patient hasn't opted in. So we use it primarily for treatment, but we also see that it's a platform that we can build off of. And so we are in line with DaVita, they're on the roadmap, and also the DoD to connect with them as well, all for patient care purposes. We think that connecting to DaVita is going to be huge. As being a former radiology interventional nurse, I've declotted more dialysis grafts than I care to remember, and I will tell you that having that type of information is critical for both sides of the equation.
Thanks. What really resonated with me out of your guys' responses is it seems like eHealth Exchange has taken a lot of the work out of what your guys' HIEs previously had to do and freeing up almost your guys' time to focus on new initiatives or maybe initiatives that didn't necessarily get the time and attention that it needs. Mm-hmm. So I guess an add-on to that is, are there any examples where eHealth Exchange has made some of your guys' operations easier?
Efficiency, absolutely. When you're paying attorneys $300, $350 an hour to do contracts, it's really nice to have one contract and you're not going back and the coffers are going out to the legal teams. But we really appreciate that. That's streamlined the contracting significantly. We also like the approach that eHealth Exchange is an unbiased entity. And they're there to help coordinate exchange. And so you don't get into all the state politics and all this other stuff that can sometimes be an impediment.
Yeah, I would just say ditto. I think the hub and the care quality on-ramp is going to be very important for us. We were trying to figure out how we were going to get involved in care quality separate, and it was not going to be inexpensive for us to do. We dropped that project once we knew where eHealth was headed. It's also a little scary. I'll be candid. There's a lot of business threat to us with everything that eHealth and Care Quality and Commonwealth and TEFCA and everything is doing. So at the same time we're making these strategic decisions, we're also really engaged with our stakeholders about what do they need us to do and be in this ever-changing interoperability landscape. I can't say we have all the answers currently, but like I said, eHealth is a really critical part to our strategic plan for the next 3 years.
Specific to efficiency, I think in the state of Maryland, we have a pretty unique relationship with CMS in the way that we go about trying to determine if we can lower costs and improve outcomes. And so we have a great relationship as a state. And in the past 2 or 3 years, we've spent millions of dollars on trying to do last mile connectivity into some of the ambulatory markets and the post-acute markets. And quite frankly, we've only been marginally successful in capturing some of that data. And I think, you know, I look at the national networks, kind of all three of them all together as a partner to say, hey, how can we be more efficient if these things are building and we can federate into those data sources? There's just not, we don't need to spend additional federal monies or state monies to go and reconnect 4 or 5 times to the individual provider groups, et cetera. And I think that's why, you know, CRISP is saying point of care data delivery, absolutely, that's not something that we need to focus on any longer. That's going to get taken care of. Now, there's other things that I think we do need to focus on with point of care data delivery, and that's data curation. We talked a lot about duplicative data today already in some of the questions. We see a lot of that happening. You know, as we're a Commonwealth participant, eHealth, care quality, we only want to add in additional data. And I think that those types of things are regional. The regional governance around, we can talk about this later, but you know, social determinants of health, I think that's, everybody says that, and I personally don't understand exactly what it's going to be. But I think our public health departments that are local, I think that those are things we need to start thinking about. And you know, at CRISP, we're trying to push the limits in Maryland on, you know, how do we get vital statistics into, you know, the point of care data? How do we get, you know, PDMP pushed into the provider's workflow? And the way we focused on the in-context delivery of deduplicated, curated data for individual types of providers, I think that that's where future work should be focused. Once we've gotten the interoperability and the data's flowing, where is the relevant business opportunities, either regionally or nationally, to say, this is how we make interoperability better?
Yeah. So there was a lot of great points that you guys made during that discussion, and I want to tie that back a little bit to what Jay was saying about his Thanksgiving discussions, where most people assume that interoperability and exchange of data is kind of seamless, right? It's almost a given, when it's not. It takes a lot of work, a lot of effort, and eHealth Exchange has made that significantly easier for many of us, which allows us to focus on newer initiatives. So that's a great segue kind of into my next question about what additional use cases are your organizations looking to use? So purpose of use treatment has been around for some time, and you know, there's some exchange for the purpose of use coverage, but is there anything additional that your organizations are looking to do?
Well, I think maybe not an additional use case, but what I like the direction that eHealth Exchange is going is, let's don't just talk about connections. Let's talk about robust data going through, because there's a lot of connections out there that if you're still sharing PAMI data and that's it, that's really not much value. So let's talk about those discharge summaries, those clinic visit summaries, procedure reports, radiology reports. Those types of things, that's where we really need to be focusing on, not just is point A and point B connected. That doesn't mean anything as far as I'm concerned. The other thing is, I think, is that we need to start, you know, maybe looking down the line about, what about advanced care planning? If we're gonna have a national robust network, if a person summers in Wisconsin and winters in Florida, and they have advanced directives, what a wonderful way that would be to keep that information, you know, flowing and what have you. So those are some of the things that I see. I not necessarily new use cases, but really focusing on and making what we have as robust as possible, so it brings the most value to the providers and the patients.
Yeah, I would add, I think we've spent a lot of investment over the last year and a half enabling bidirectional exchange between health plans and providers. So we have about half of the plans in Ohio. We have about 12 million people. About 6 million of those are represented with the plans we're working with. And we have a simple philosophy, going back to my earlier question. If you want to participate, you have to contribute data. So that's, if you want to play in the sandbox, everybody's got to be equal. So for the plans, that means claims, pharmacy, attributed provider, member files, risk flag, things like that. And we've created an environment where the plans are pulling the clinical data. In January, the providers will be able to pull the claims data back. For us, where eHealth fits into that, going back to what Brandon said, it's impossible, even as big as we are, for us to get to every ambulatory and post-acute care facility in the state. I mean, there are thousands of those, and we're hoping that our connectivity through care quality, through the eHealth, will dramatically increase that availability of that data. Because here's what's important about that data. If you look at the value-based measures, if you have like the 40 most common ACO value-based measures, where the data comes from is primarily from the primary care visit. And if you don't have the primary care data, then you can't meet some of these quality reporting requirements, and that's critical. So even though we have about 23,000 providers in the state, about 13,000 of them are employed by health systems, we have that data, but there's another 12,000 independent providers out there that data is incredibly valuable to everybody that we're talking about. So that's where we see, we hope to leverage the eHealth Exchange platform.
So those are great use cases. When I think about use cases from an HIE perspective, I'm going to talk a little bit about, I think, a use case with eHealth Exchange and Care Quality Commonwealth is, what are the components of shared infrastructure we can use? Specifically, I think that there's needs out there. If you look at the map, I'm staring at it, like all of those HIEs have spent millions and millions of dollars on vendors to implement a CDR or a consent engine or all of those different types of things. And I think it's more regional governance that's important, and maybe shared infrastructures are the things that are going to be better served as we think about interoperability. So from a CRISP perspective, the types of infrastructure that's missing nationally are things like consent. And we preach this pretty hard in Maryland, like the opt-out requirement and the patient understanding of how this data is flowing across this network. I know consent is pushed out to the covered entities, and we have our notices of privacy practices and things like that, but I think as we talk about consumer access and we think about consent nationally, do patients want to have that governance only at every organization that is a Care Quality or eHealth Exchange member, or do we want national infrastructure for opt-out, opt-in, other types of consent? I think the other types of shared consent use cases that I would love to pursue with eHealth Exchange are relationship management. I think I call it relationship management. I think in the past, our HIEs have called it record locator service. I think those types of things are going to become more important as we talk about FHIR-enabled resource calls for specific tidbits of information that can be curated and served up to a cardiologist. Those types of things are going to be more important as the data and the underlying data connectivity becomes ubiquitous.
Okay. That's
Can I, one of the things that I think Brandon brought up that is incredibly important is there is a data governance role from a statewide health information exchange perspective, where I think we can bring to the table to the national networks is some data governance, but also, even more importantly, data usability. There's one thing to talk about interoperability. There's another thing to talk about data usability. Mm-hmm. So we push or pull approximately 20 million transactions a month to or from between providers for interoperability. So there's a lot of interoperability actually happening. The problem is, if you really dig into that and look at what data is actually being used, it's not the same story. And I have a big concern that we're going to put all this effort into interoperability, and what we're going to find is not going to have the impact that we really had hoped. So I think there's a usability piece that eHealth a role can play, and we can help. I don't know exactly what I mean by that, but I think that's an important part of the conversation.
Yeah, absolutely. So interoperability is such a, I guess, a cube with so many different facets of how to really make it successful. So even though it's been around for a long time, and even the VHA being so interconnected, there's still more of that point A to point B that you were talking about, Mike. And then in addition to your guys' comments, there is still the additional piece, which is, just, I guess, barely being skimmed at the surface of the data usability, the right data being there at the right time for the right person.
It's implementation versus utilization.
Oh, absolutely.
It's what it gets down to. And I think, too, eHealth Exchange has got nationwide attention. So I think that there's going to be ways to maybe help some of the vendors. What we hear occasionally is that it's not that there's not good data in there, it's too hard for the provider to get to in their viewer internally inside, and they don't want to go to a portal. They don't want to have a separate portal, separate sign-on. So they like the view that we provide, but they don't want to go to a portal to get it. So I think that might be some ways too to get the attention of some different the vendors and make the accessing of the data easier, because that is really troublesome for a lot of the providers. Our CMIO says that each provider is born with so many clicks, and once you exhaust those, and so we're very attuned to that.
Yeah, that's a very good point, and I think we all face that. God forbid there be another sign-on that you have to do with another interface. And then finally, I guess the kind of last question would be to, in addition to some of the things eHealth Exchange has already commented on and what they see in their roadmap, is there anything that you all would highlight out of there, or is there anything additional that maybe they didn't mention that you would like to see eHealth Exchange focus on?
Go ahead.
So there's a couple things. In one, I want to clarify something I said. We do about 20 million a quarter, not a month, so sorry, I misspoke there. So there's a couple things on the roadmap. One that I just don't know. So we do a lot of notifications, a lot of push of data. I sit on the Direct Trust board, so the push of information, I think that I'd like to see maybe a collaboration between the two a little bit more if we're going to start talking about push. And I get concerned that, both have significant opportunities, and I think we need to kind of figure out how those two fit together. I also will say one of the things that I think gets left out of the interoperability conversation is referral management. That's a big initiative that we have going on in the state. And what I would say about that is we're at a point now that providers are not going to get outside the workflow to manage referrals. It's not going to happen, and it's not going to be successful. So we have to figure out a way to manage referrals inside the workflow, figure out a way to get social services engaged, to get other entities engaged in this process. And I think both Direct Trust and eHealth can have a role in that. And I get concerned, again, about all the different efforts that are going around referrals across the country. I mean, if you look at Ohio, we have 10 different projects going on just in Ohio, and a lot of money being spent. And it doesn't seem like there's any consolidated effort at the national level to really address this issue. So, we've talked to several, mostly health systems that are doing some pretty creative things around referrals, Sutter Health being one of those. I'd really like to have a conversation around that at the national level.
For me, I think the one thing that CRISP is trying to push the limits on is Da Vinci and payer engagement with those FHIE resources. And as I sit on some of the subcommittees and the task forces at the ONC level, I don't see how it's going to scale appropriately. And I feel like organizations like eHealth, Care Quality have a big opportunity to do directory versioning and scalability at the FHIE resource level to eliminate some of the lessons we've learned in the past around HL7v2 scalability, as it seems to be maybe, I don't know if it's an RCE thing or eHealth, or someone should be leading that charge around how do directories get created so that payers can onboard to some of this data exchange in a more effective, efficient way nationally, versus independently at each one of these HIEs that might stand up their own FHIR or Da Vinci resource directory, et cetera, that connects in. So you're going to have a lot of the same type of, I think, challenges that we've had with just provider-to-provider connectivity as we engage the payers at a different rate. So that's a conversation that I think should be maybe more formalized. I know they are happening. Dave and Jay are doing some of those things, but I think that would be something that the HIEs would like to understand what that roadmap is so that we don't duplicate efforts.
We're really excited about eHealth Exchange and the QHIN. I think that's something that we really support, and hopefully that moves forward. A couple other things that I think if we had a wish list that we'd like to see is potentially more proactive testing to be able to test connections with folks, and with the new hub roadmap. Oh my gosh, that's going to be phenomenal that we can actually see what's going on. That's huge, but we'd really like to be able to do some of that proactive testing, because there's things that go on that we have no control over, and the folks have been told by their vendor, oh, this won't affect your connection. Yeah. So it doesn't always work that way. The other thing I would think is a huge opportunity potentially is if we could get not so much the Federal Bureau of Prisons, but state correctional facilities engaged, because most of those are the largest or the second largest behavioral health systems in each and every state is their prison systems. And by being able to have that information and share that, because a lot of those organizations outsource that care. They take them to their regional hospitals, community hospitals. They don't have those facilities inside to do radiology procedures or surgery. So they go to other facilities, and the records is very much lacking when they're sent to those facilities. It's not a seamless electronic means. So that would be one I'd love to see.
Those are all great suggestions and comments. What I really liked about what you all said, and it's been enlightening hearing you gentlemen speak, is that there is so much left in our ability to tackle. And just in this 25 minutes that we've been talking, you've listed out so many things that us as an industry still need to tackle head on. And I don't know if that's enthralling because it means that there's so much to look out for in the future, or if it's almost
It's job security.
scary. I was going to say scary because there's so much left to do. But that's in any way, shape, or form. It's still great that we all have jobs still. In our last 3.5 minutes or so, are there any questions from the audience for these gentlemen?
Hi, so Paul Matthews with OCHIN. First one, absolutely, referrals management coming from a safety net organization. Referrals is our biggest problem in this country today. Second one, looking at shared infrastructure in the conversation earlier, if we're all eHealth Exchange participants, being able to both push a CDA document to an exchange via eHealth Exchange, which has been demonstrated, we would love to do that in every single exchange that's on an eHealth Exchange today, anywhere in the country. And secondly, if you're already live on eHealth Exchange, we would love to be able to work with the HIEs and pull information via eHealth Exchange. All too frequently, what we get in the questions and the conversations is, yes, we can do that, but you have to use a custom XDSB connection. But if we're already connected, why aren't we using the infrastructure that's already there? So,
I'll take that. So we do that. So we're onboarding DaVita. I think actually we're having the conversation with you guys about the same thing. It depends on the level of participation in the community. So eHealth provides a valuable piece of infrastructure, but there's additional things that are also as valuable, that whether it's notification or more in-depth data for patients that may not be queried. In other words, that data may not flow for quality improvement or data sharing between somebody who might be responsible for that patient other than the FQHC. So yeah, we can absolutely do that. And again, our simple philosophy is you need to exchange data to be on board, so that does satisfy that need. And what we do is we just take those conversations one by one. At what level do you want to participate? Because if you do it through the eHealth Exchange, great, but you can't have access to these other services that we provide. So that's kind of how we're balancing our business proposition with the national networks. So yes, we would absolutely agree to that.
I think we have a little bit of a different approach where we say if you're already an eHealth exchange participant, then you can have access to our federated data as part of an eHealth exchange participant as well. There's certain types of data that we curate and serve up in Maryland and District of Columbia. Some of that is Medicare and Medicaid claims data that we package back up and could come in the form of a CCDA. So we don't have quite the same thing that Dan's talking about, but if you query eHealth Exchange and CRISP is on that node, and you have access, then we would serve that data up from wherever.
Yeah. And that's the reason we're moving to the hub. So, any hub participant, great, it's there.
And then one other follow-up question, which is on the referral side of the house. Have you guys looked into Project 360?
Yes. So what yes, we have. We're looking for real-world use cases. No. Sorry. We're looking for real-world actual use of the referral infrastructure because we just want to make it happen. And there are some, again, I mentioned Sutter Health, Children's of Dayton, some other health systems we've talked to. There is actually some incredibly creative things that they're doing in the referral. And I don't know what the right answer is. It's just that we're trying to get people moving in the same direction, whether it's that project or something different. It's hard because everybody's doing something different. So. And
we've created an open source referral capability where providers are able to send a referral to diabetes prevention programs or someone outside the normal care community, because that's kind of the piece that our state government has said, hey, this is the problem. We want to get people into these non-clinical settings, and how do you do that? So they've come to us and said, can you just build this and create the appropriate workflow for a provider to send a referral to an organization that can then contact the patient, but it's kind of provider-led referral, and then we close the loop with a notification capability. So very basic piloting of these types of workflow. I think the biggest referral problem that I think the District of Columbia has and Maryland is your directories of all of these separate, and there's 5 or 6 vendors out there that, your 211s and others that are doing the provider directories, and they're just not always complete. And those those CBOs are not necessarily equipped to be part of the referral process as we think about it today.
Yeah, that's the toughest part right now. I'm working on a couple of integration projects with FHIE, integrating to social agency systems through some of those vendors. Mm-hmm. And the issue is this explosion of subcategories.
It's crazy.
So you might have 20 categories of referral, but you might have 200 subcategories. So, okay. Thank you.
Kevin Larson, just wondering if you could speculate a little bit. 50% of HIEs participating is fantastic. It's also a 50% opportunity. And why do you think the other 50% are not yet participating, and what can we do to help get them on board?
I think some of it has to do with financial reasons. I think that they're concerned that they're going to be losing market share by going through the national agency, and I can't tell you that wasn't a concern that we first had, but to be honest with you, when I started this position 8 years ago, my board told me, your job, your number one job is to work yourself out of a job. Mm-hmm. We should not need you in 5 years. Well, I've sorely disappointed them. So I'm still around, and we're still around, but I think that's some of it. I think also it's just a little bit of confusion in some aspects. I did a information call with Sheik to kind of provide some overview of the DIRSA and what have you. And there was a tremendous amount of folks that didn't have the correct information. They had read more into it or were confused or what have you. So I don't think there's one silver bullet. I think there's a lot of mitigating circumstances.
Yeah, and I would think the biggest thing is it's scary. I mean, we've spent a lot of years trying to get these networks up and running and these organizations sustainable, and many still aren't sustainable, and it's a threat to the business model. In our particular case, our board has said, go for it, and let's just do it and let's see what happens. And it's because it's the right thing to do. But I think there's some turf battles. Again, you look at the roadmap that they put up, it's scary to a lot of the health information exchange organizations out there. Care quality is scary. Commonwealth is scary. QHINs are scary. I mean, that's why everybody has gray hair that's sitting up here. So I think the reality is you have to embrace it. Those that don't, unfortunately, I'm not sure are going to be around in 5 years. So
I also think you have to remember the HIEs that are represented up here. We're nonprofit organizations that are meant to have a mission. Our mission is not to make money. Our mission is to share data locally and share that governance structure. So when there is this mindset of competition, or I think, quite frankly, I think all of us, local, regional HIEs, eHealth exchange, care equality, we need to have better conversations about this to say, why are there areas, why aren't people on board? This is where we all need to collaborate together, and I think that's what's going to solve interoperability. We're all competing like we have equity in these companies. We don't. These are all federally funded organizations for the most part.
no, we're not.
All right.
I just want to
Sorry.
We're not either.
Sorry. Then me. We're federally funded, state funded, and we have a mission we don't exist to exist. When eHealth exchange and care quality do what we do, we'll go away.
Okay, one more.
A quickie. Stephen Lane, Center Health. So are any or all HIEs in a position to become QHINs, given what we know about that?
No,
No.
no.
not even close.
Thank you.
That was
I will say there are a lot that are. I do believe, and again, in Ohio, we've acted as a QHIN for years, but we're not going to build our focus is Ohio. That's our mission. Yes, we work with some outside of it, but it's not our mission to build an infrastructure to satisfy this bigger need when we could use eHealth as that solution. So it just would be a capital investment that we couldn't sustain.
And I just want to make one kind of lasting comment that resonated with me from my attendance at the CHIC annual conference is that, we've heard a few times up here today that all these changes can be scary and they could be a threat. But I think walking away from CHIC, one of the resonating themes was that it can also be seen as a catalyst for opportunity. And I think that that's what's going to keep the various organizations kind of in the running game. And with that, I thank you gentlemen for your time, and I think it's time to eat lunch.